I'm Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and it pleases me to introduce Dr. Pam Venenchek, the Residency Director from Lancaster General Hospital in Lancaster, Pennsylvania. Dr. Venenchek, the show is yours.
Great. Welcome, everybody. Sorry for some technical difficulties, so we're doing a little bit of last-minute juggling. Again, I'm Dr. Pam Venenchek. I am Program Director of the Lancaster General Family Medicine Residency Program in Lancaster, Pennsylvania. I am also a member of the FMEC board. My co-presenters for this next hour are Dr. Bill Fife, who will be joining us a little late because he is covering labor and delivery and things are a little busy. And then also Dr. Cherise Hamblin, who is an OBGYN, there she is waving, who is an OBGYN physician who is part of our faculty. And she is also the Officer of Diversity, Inclusion for our residency program. So I'm excited to be sharing the Zoom call with them. A little bit about me before we jump in. I have been doing maternity care for the last 27 years since I graduated from the Lancaster General Family Medicine Residency. The first 3 years I was in a very rural practice in rural New Hampshire at a small 50-bed hospital. The OB department there were 6 of us family physicians and 1 OBGYN, and our little hospital did about 200 deliveries a year. After that, I joined faculty at a residency program in upstate New York, where I was faculty at a residency program, did the prenatal care in a rural center, and then delivered in Syracuse, New York. And then for the last 27 years, I've been here in Lancaster. Dr. Hamblin, if you would introduce yourself, and then we're going to review a few slides that I'm hoping will just lay some groundwork, maybe provoke some questions, and then hopefully this next hour will be a dialogue so we can just answer questions and hopefully share ideas.
Wonderful. Well, I'm Dr. Cherise Hamblin. I am a graduate of Franklin and Marshall College, and that's how I got introduced to Lancaster. I'm from the Bronx, New York, so Lancaster was not on my radar, and I ended up visiting here as a sophomore in high school, and Franklin and Marshall and the Lancaster community just grew on me. When I left after graduation, I went on to Northwestern for medical school and Phoenix for OBGYN residency. And I ended up joining my mentor from undergrad in his practice. So he was one of the in-house OBs. So as Dr. Venenchek mentioned, our service is very busy. And at Winnie Babies Hospital, we deliver 5,000 women a year.
Yeah, the whole hospital, about 5,000.
The whole hospital, yeah. And so it's a busy women's hospital, and the family medicine residency program is supported by OBGYN physicians. And so we have our office practice, where I'm sitting in my office right now, where we have full-time and part-time OBGYN physicians who provide full spectrum care. And part of our job is faculty teaching the family medicine residents on their OB service, and also supporting the hospital for emergencies and drop-in patients. I also am very committed to diversity work, where for the last 9 years or so, I've had some informal, then becoming more formal relationships with pre-med students, helping underrepresented minorities in medicine achieve their goals of going to medical school, first starting with my alma mater, Franklin and Marshall College, and then broadening those efforts. And so you might see my pin that says patients are waiting. And so the residency has been very supportive of the things that I've done outside of the residency, and we actually have figured out how to bring those things together, because we understand that when our healthcare community reflects the community that we serve, we will have the best outcomes. So I will share the screen so that we have our slides up.
Perfect. And while you're bringing that up, Dr. Hamblin, I believe Dr. Fife has been able to join. So Dr. Fife, if you would please introduce yourself.
Sure, Dr. Venenchek. Thank you for introducing the topic. And so I am Bill Fife. I am one of the faculty at Lancaster General Hospital. I have been there for approximately 6 years. I actually went to medical school at SUNY Downstate in Brooklyn, and then came to Lancaster about 23 years ago now. I came to Lancaster as a resident and went into the residency for 3 years. And then after that, went into practice in a small community in Columbia outside of Lancaster. It's about 15 miles outside of Lancaster in a full scope family medicine practice. We practiced in the ER, we practiced obstetrics, we practiced substance abuse with an addiction unit, it was called at the time. I think it would be called differently now. And we also did inpatient medicine service. And I worked there for 4 years before moving to a community health center that's in Lancaster City. It was known as Southeast Lancaster Health Services, and now it's known as Lancaster Health. And so it actually changed over time, but I was their medical director for about 10 years, and we served a population of both underinsured, uninsured patients in an FQHC model, or a federally qualified health center model. In that model, we partnered with the residency. With the residency, we would do actually our deliveries or take care of women in labor and take care of them while they were pregnant. And we still actually have maintained that relationship now with Lancaster Health Center. And so they take care of patients prenatally, and then they come to see us during delivery, and some of their attendings are also within our call schedule and take care of our patients as well. So we have sort of a partnership with a federally qualified health center, and that was a place that I worked for 10 years and did obstetric care as well there, and prenatal care as well there. It's a unique population with a large number of refugees. There's a refugee health elective that or refugee health clinic that you could actually be part of our community health clinic, which I actually run our community health rotation. And after being there for 10 years, I went to the faculty. And fortunately, I was allowed to maintain a good number of my patient relationships. And I took about 350 to 400 patients with me to Lancaster General, and was able to still maintain care of those patients as well. And now, as a faculty, I do full scope family medicine. I was just on OB, and I just got actually out of OB, and I just made it home. And we had a very interesting day, as always, on our obstetrics. I also do HIV work. So over my entire time with all of those different roles, I have maintained a continuity practice in our HIV medicine office and take care of about 50 to 100 people with HIV, living with HIV in our community. Our overall office takes care of about 700 to 800 patients living with HIV in our community, and have taken care of a good number of my patients who actually have been pregnant. And very fortunately, we have not had any vertical transmission or any mother to child transmission over that time period. So that's something that's kind of interesting and unique about our Lancaster practice. We partner with our Ryan White funded clinic for patients with HIV. So I have multiple interests, but we can kind of begin with the program.
Great. Just so that way I can make sure I try to address things appropriately. Students, if you would put in the chat your year of medical school, that would really be nice. Okay. And also, if you're able to stay on mute, that would also be helpful. So in the year 2000, the American Board of Family Medicine reported that approximately 23% of family physicians provided some maternity care. 10 years later, that had declined to 10%. And in the most recent American Board of Family Medicine graduate survey, this is a survey of recent graduates who are 3 years out of residency, 13% of those were delivering babies. When you're looking at residencies, if you want to do maternity care, factors that increase the likelihood of its graduates delivering babies include family medicine maternity care preceptors, family doctors who are actually doing maternity care, the ability to get over 80 deliveries for yourself over the course of residency, and settings where family physicians have autonomy in the care and decision-making of their patients. And with advanced training, family physicians can go on to perform cesarean sections. Most of the time you would need to go on to do a fellowship to do that. Next slide. So the next slide is the estimated percentage of deliveries, and this is going to be really hard if you're on the phone, I'm sorry, of deliveries performed by family physicians who do practice obstetrics. So between 2013 and 2016, and this is from the American Board of Family Medicine. So, over time, deliveries, as we have described, have declined. About 2% of family physicians do high volume obstetrics, over 50 deliveries a year. We're now at about 2% who are doing medium volume obstetrics, between 26 to 50 deliveries per year. And about 5% are doing low volume obstetrics with 1 to 25 deliveries per year. Next slide. All right, if you're on your phone, again, I apologize. This is going to be hard to read, but actually I think it can still be impactful. This is looking at rural counties across the United States. And this was at a study that looked at obstetric care in rural counties between 2004 and 2014. The areas in black are areas that had closure of their maternity care. So those counties over that time lost their maternity care. The lighter blue, there was still some care, although the number of providers declined. And the darker blue actually had no maternity services during that whole time. So if you look at all of this blue and dark area, these rural areas are underserved or have no obstetric care. And we know infant mortality in rural counties without obstetric care, the infant mortality rate is about 9.23 per thousand women. And in rural counties that have continuous care, the infant mortality rate is 7.89. So this is affecting the lives of babies. And also the rate of low birth weight is increased in communities that do not have obstetric care. Also, in many of these counties, non-Black Hispanic women of reproductive age and lower median incomes are especially affected by these rates. In rural America, ACOG, the American College of Obstetricians and Gynecologists, have recognized that most rural counties do not have OBGYNs. OBGYNs prefer to practice in urban areas. Family medicine residents and graduates are more likely to provide care in rural areas. And family physicians really share a disproportionate share of deliveries in those rural communities. And as I mentioned, traveling to maternity care service is associated with worse perinatal outcomes. Rural America does not have enough cases for OBGYNs to deliver the majority of babies. Family physicians who are living in rural communities, when they're not delivering babies, can address other patient concerns. They can take care of that whole family and provide whole family care. And studies have shown that maternal and child outcomes between family physicians and OBGYNs who provide maternity care, including cesarean sections, can be equal. Next slide. there has been increasing examples recently in the last 3 or 4 years of communities that are relying on family physicians to provide maternity care and help to start to turn that curve around, to try to turn some of those black or dark blue counties that were in the earlier slide into a better served care. Next slide, please. This is a screenshot of an article about a town in Kansas where Kearney County Hospital, they lost all of their maternity providers, and they rely now entirely on family physicians to do their maternity care. And this is a county that, again, is very rural. There's a Tyson meatpacking plant where there's a large refugee population that are serving. So family physicians have dramatically improved the outcome and care for not only women, but also minorities. And so this is really an opportunity for family physicians to make a huge impact in their world. And many rural communities have great loan repayment programs, and that's has been some of the enticement that some of these health systems have been using. Next slide. A little bit about obstetrics and maternity care at our residency program. Both Dr. Hamblin and Dr. Fife shared a little bit about our model. So our residency program has a total of 39 residents. So 13 residents each year. We're a 3-year residency. All of our residents have 5 months of maternal child health, 2 in the intern year, 2 in the second year, and 1 in the third year. Dr. Fife and I are part of 14 family medicine faculty. And in addition, there are family physicians from the federally qualified health center that Dr. Fife mentioned, as well as a community family medicine practice. And we are the family medicine support and mentors for our residents. Dr. Hamblin is one of 8 OBGYN faculty who were hired and are dedicated to being the backup for our residency program. And last year, our residency delivered over 1,000 babies. And our residents routinely can achieve over 80 deliveries a year. Not all of our residents enjoy maternity care as much as Dr. Fife and I do. And so some of them will trade out, and that works out really well. Our residents are able to tailor their experience. And so if residents want to opt out of some call for the residents who are more interested in maternity care. So it really is a beneficial situation. And we deliver women from a wide demographic. We deliver women from our urban family medicine center called Downtown Family Medicine. We also have a rural family medicine center that all of our residents practice at. We deliver the babies from there. We deliver the babies from the federally qualified health center. And Lancaster, as Dr. Fife alluded to, has a very diverse refugee population. In addition, 2 family practices and the babies of the practice where Dr. Hamblin practices. So family and maternity medicine that has 2 locations, one of which is rural. Next slide. The prenatal care we deliver occurs, we do a lot through the traditional model of a mom coming into the office and seeing her provider one-on-one. But prior to COVID, we had a very robust group prenatal model called Centering Pregnancy. And as soon as the COVID pandemic becomes more manageable and we can once again have safe group visits, we plan to reinstate that. And that group prenatal care has been has helped to improve outcomes for our patients and has been a wonderful satisfier for our residents. In addition, our residency program participates with the Implicit Network, which actually is a project that got its start in the FMEC because the FMEC brought together providers who We're interested in working to decrease prematurity and decrease low birth weight. And now the network has over 26 residency programs and health systems that are participating in this research. And so with that as an introduction, I would like to open this up for discussion. So either you can unmute yourself and ask your question, or if you feel more comfortable typing it in the chat, we will continue the talk. I guess, Dr. Hamblin, you don't need to be sharing the screen anymore.
Hi.
I'm trying.
Oh.
Okay.
Oh, you could go first. Sorry.
And I was just going to say, when you ask your question, if you would introduce yourself, please, just, who you are, where you're from, just so we know a little bit about you.
Okay. Hi, I'm Kayla. I'm a fourth year at Howard University in DC. I just had a question. I know you said you'd probably have to do a fellowship if you want to eventually do C-sections. At the program at Lancaster, are residents able to do C-sections if they're available?
Yeah, and actually, Dr. Hamblin probably can comment on that. So residents have the opportunity to scrub in to C-sections as part of their rotation with seeing patients. But in addition, we offer an operative obstetrics elective. And Dr. Hamblin, do you want to talk a little bit about that?
Sure. So residents are more than welcome to come to C-sections. Our setup on labor and delivery at any given time, you will have two residents. We have a night float system. So you'll have the day team and the night team. There's this FP attending who's on and is in-house, and then there's the OB attending who's on and in-house as well. So as a patient, our team will meet and have morning sign out and afternoon sign out, and in the morning, our whole hospital does whiteboard rounds, and in the evening as well. So you have these, these teams of 4, whether you're day or night, and then you have these touch points of rounds together as a team and then hospital rounds. So you're kind of getting an idea of what's going on. Any patient that the OB is taking care of, so we take care of like a subset of the patients who are on family health service on the labor floor. And any of the patients that stall out or end up going to C-section for non-reassuring fetal heart tones or category 2 tracing, or even if there's a crash section, the residents are always able to join in. Because they're true residents, basically if you have a very interested resident on service, they will then hand their phone or forward their phone to their upper ear. Usually it's the lower ear resident who's interested. By the time the upper ear resident, they've decided, they figured out if they really love it or not. Yeah, but there's that opportunity. It just is a matter of balancing things out. And then for residents who are really very interested in getting more experience in the operating room, sometimes this happens when a person's trying to figure out if they want to do an OB fellowship. Many times they'll then choose to do an elective on service with us. So part of the program is you do have a GYN month where you work in this office and do colposcopy, endometrial biopsies, other GYN procedures, and see consults that we see in the office. But then you had the opportunity to, I would want to say it's third year where they have where you have an opportunity to do electives where you can figure that out. And I think a lot of that decision making about whether or not you want to do an OB fellowship has to do with where you want to practice. Like Dr. Vanenchek said, if you want to practice in a rural setting, those can be some really awesome skills, but you also have so many delivery opportunities and so many opportunities to get in the operating room here because we are an unopposed program. It's not like you're fighting with OB residents to get cases, that then you have the chance to really craft the experience that you have based on what it is that you want to do down the road.
And in addition, our So all of our residents have 5 electives they can use in the second year and in third year. And again, this is when there's not a COVID pandemic. You can take 1 elective in your second year, 1 elective in your third year, and go away from our health system, including international. So a number of our residents who are interested in maternity care will go to our sites that we have agreements with in Tanzania or Malawi, and get a lot of delivery experience there, as well as some C-section experience.
Thank you.
Hi, thank you so much for the session. My name is Trisha Quarko. I'm a 4th year at University of Connecticut. I'm highly interested in, knowing about OB and family medicine. As a current applicant, what would you be looking for? Like, how do we make our applications stand out as, students who are particularly interested in, exploring OB further? For example, do we need letters from like an OB attending, or, electives, or in our transcript that shows our interest, or any other advice that you would give?
Well, we're first and foremost family physicians, so we really appreciate the diversity and just really understanding family medicine. And as I mentioned, all of our residents have this maternity experience, so it's not like you have to sign up for a track. However, if you do have particular interest, we're now up to 17 areas of concentration. If you do have a particular interest, like you're like, oh, I want to get even more OB experience than what everybody gets, or if you want to do HIV medicine with Dr. Fife, or if you want to do clinical genomics at the Clinic for Special Children, or sports medicine, you have the option to choose those. But again, there's no pressure, there's no time limit. So you can decide if you want to do one of those areas of concentration, or if you want to continue to stay broad, that's totally fine. I think for your application to stand out, if you can have letters from family physicians, but I also understand this year has been crazy, and people's clerkships have been canceled, or for medical schools that don't have family medicine departments, they may not have had the opportunity to rotate with a family physician. But if you can just in your personal statement or through your activities, just to help explain, what it is about family medicine that attracts you.
Okay, thank you so much.
And Trisha, you said you're coming from UConn, is that right?
Yes, I am.
Okay.
Do you have any time?
Yeah.
Old, way old.
Oh, okay. Awesome.
Right. Yeah, Laura Hatchman, who's one of our current second-year residents, is from UConn. What other questions do people have?
Hi.
Hello. Oh, sorry.
Go ahead.
Okay, my name is Fabian. I'm an IMG graduate. I graduated in 2015. I noticed that you were talking about your program is really affiliated with just like the underserved population. I wanted to know how your residents actually work with just the community, any type of educational outreaches or anything like that. Do they involve themselves in that, or do you run any programs to help the community in regards to preparing for pregnancy, etc.?
Dr. Fife, this sounds like a question for you.
Yay, Dr. Fife, tell me the good news.
Yeah, as you talked about community, I thought this might be my time to come in.
Yeah.
So I help coordinate the community medicine rotation in your first year. The community medicine rotation actually starts in orientation, and in orientation, my partner in coordination is Dr. Jeff Martin, and the two of us run a scavenger hunt so that you actually get to know all of the important community activities and community organizations that provide care for our patients. So you actually go around the community for a day, and you get to meet people on a regular basis, and we give you questions to ask them, and then you come back and we share the questions and the answers that you have received. So that's the first part. But the second part is a full month. And so for the 4 weeks of this rotation, first we have built in about 10 different experiences that you have in the community with things like we have a refugee clinic, we have a homeless clinic, we have time with IU13, which is child development. We have time with our community, community health workers that go to different people's houses and meet with them. We have actually an outreach program through what's called Care Connections, which is our program that takes care of our patients who have utilized healthcare in a way that's probably greater than many. And we have you follow those community health workers, and we have you follow the social workers and follow the physicians and the nurse practitioners that go to people's homes. We also have you do a home visit within this as well. So you actually do a home visit on one of your patients. And then one of the other pieces we have is that you pick something that you want to be more knowledgeable about and to share that knowledge with everybody else. So we have a morning report, and our morning report in that basically it's a 7:30 to 8 o'clock where everybody gets together and you learn about a specific topic. And one of the community medicine rotation experiences and activities is to give a community medicine talk, and you give a talk based on what you've learned. So there are people who've visited the prison and learn about care of the incarcerated. There are people who are doing, like the person who's doing it right now is doing it on climate change and the response to climate change in Lancaster area in general. People have done it on the school-based health. We helped set up a school-based health clinic in the local high school. It's our local high school. It's actually where my kids went to high school, McCaskey High School. And it's a very big urban high school. And we set up a community health clinic there as well. And so you could have time there. And one of our residents was pretty essential in working there and setting it up. And now she's one of the physicians who runs it. So there's lots of opportunity for outreach within that month, but then we have potentially an expectation, but more of an opportunity that you might actually keep connected with the organization that you reached out to. So we have one of our former graduates who had a large part in trying to map the city in terms of bicycle routes. And he works at one of the former practices that I worked at, and he's still very involved in that. And so there are a number of different things that we actually hope that you'll get involved in the community. Your third year, you can actually also do some community medicine focused activities in some type of rotation. So it's typically an elective rotation. So I've had a number of people who've had focus on urban healthcare, and I'm the faculty coordinator for our urban healthcare AOC. And so I try to set up people to go to different places to get experience in urban healthcare. One of those being the Federally Qualified Health Center where I used to work. So we actually do put a preference, and we really have a great interest in reaching out to the community as a whole. And I actually look forward to working a little bit more even with Dr. Hamblin on that too. She has done great work with reaching out to underrepresented minorities in our community and doing teaching. And so we've had spurts of that like through the residency, but I think it's become more formalized over time. And so I'm hoping that we can actually even incorporate that into the community medicine rotation, into the electives, or even more broadly into a more continuity experience. We actually do have a lot of innovation that goes on. Our curriculum is anchored by a number of rotations and very important clinical experience, but on top of that is a lot of innovation in terms of how to learn and how to connect more with community and how to just be a better family physician as you go out into the world.
Right. Thank you so much. No, that was perfect. Amazing.
Great.
Thank you.
Well, and I want Dr. Hamblin to just talk about some of the work that she's been doing in the community.
Oh, well, thanks. So I was mentioning earlier about patients are waiting. So my long journey of, the boomerang back to Lancaster, which is one of the things that happens. I don't know what they put in the water here, but it's something because you come and then you don't want to leave. Like I did not have a plan to come back here ever. And when I came back as a practice interview, I just kind of realized that there was so much that Lancaster had to offer. And so a lot of people, when you think about it, you think about horses and buggies. Lancaster City is a city of about 50,000 people. Very walkable. There's like a 3-block downtown, but there's stuff here. There's things to do. There's places, places to see, and things to do and places to go. Whatever the saying is, there's stuff here. So I was surprised by that. And then you have several schools around. So Franklin and Marshall College is like walking distance from Lancaster General, the main hospital. There's Millersville, there's Elizabethtown College, there is Harrisburg Area Community College and Pennsylvania College. There are schools around as well. So there's a variety of young people. I would not say that it's a college town, but you have this kind of interplay between like the urban and then this rural community. So you got Lancaster County and you got Lancaster City. And when Dr. Fife is talking about McCaskey, I mean, this is a school that is an urban school. Are there 3,000 students at McCaskey?
Yeah, it's about 3,000 students total.
So 3,000 students. The school has a daycare and a health center. And so, for example, some of the students that I come in contact with from McCaskey are because they're patients. They're pregnant patients. And so you see that. I'm from New York, but even in my high school, you got pregnant, you had to go to a different high school. And so you realize that Lancaster is more than horses and buggies. You have an opportunity to interact with Amish, but you also have a small city here that our hospital is a major part of. So some of the work that I do in the community was mainly started around students. With the mentoring and working with my alma mater, our hospital had also had a long-standing relationship with the pre-med office, and then also got involved with the MAPS chapter specifically because we were finding that some of the students who were pre-med at FNM were participating in the Lancaster General preceptorship, but the MAPS students, so MAPS is Minority Association of Pre-Med Students, like the undergrad portion of SNMA, that they weren't participating. We didn't understand why. And so working to try to get some more of those connections to happen and then formalizing things over time. And so Patients Are Waiting formalized as an initiative and then as a nonprofit. And so our program has been really supportive of that with being involved in our annual conference. The program is recruiting at our conference that we literally just had this past weekend.
Yep.
Yep. It was great.
Were any of you there?
Yeah.
I was. In and out, but I was. Yeah, I heard about it.
Awesome.
Yeah.
Yes. And so we also have a book club. And so the book club is What the Health. It's a health equity book club. And through this year, there's been, so much self-study for a lot of people and a lot of organizations. And so with so much civil unrest, a wide awakening to, focus on health disparities outside in organizations outside of medicine. And then you also have a focus on racial inequality and, and police brutality and Black Lives Matter from health organizations. It's kind of been a perfect storm. And so our institution, I think our residency program has been a leader at our institution really to participate in, growth and make it widely available to everyone and not just say, well, let's have a session really quick and see what we're about, or make sure everyone's okay, or just call the Black resident and see how they're doing. We actually really sat and had some intentional time talking about what are our values and are they reflected in our statements? Are they reflected in what we put out about our program? And then are they reflected in the way that we move? And so, I've been really inspired and pleased with the way that we've been doing things, but not necessarily like a coordinated effort or an intentional effort. And when we said, you know what, we actually have to be intentional, and then the other things will fall in line. It's been really a beautiful thing. So we were scheduled to go to SNMA to recruit, and then of course, COVID, and then also we actually went to RMEC in January we went to LMSA's conference at Albert Einstein. So for me, it's been a really interesting confluence of these different things where, Lancaster kind of popped up and wouldn't go away. And and it's embraced me, and I'm embracing it. And so we're doing things in and around the organization and the community. Yeah.
Great. Thank you so much.
Thanks, Reese. That was great. I wanted to say two quick things on that. So I was looking around actually for a shirt from McCaskey, but I couldn't find it. It's in my wife's drawer somewhere, but I couldn't find it. But it says it's about McCaskey. It says 3,000 students, 52 languages spoken, like 85 ethnicities, and 2 buildings and 1 school. I have the numbers probably a little off, but not by much. But it's interesting how diverse Lancaster is. It's been quoted as the potentially new Brooklyn several times in several places. And I was from Brooklyn, and I could see how that would happen.
Other questions? Oh, and also before, and again, you can either say them or type them. One of the administrators from our residency is going to be putting in a survey, link to a Survey Monkey. If you would respond to that just about this session. Our residency program, we are hosting our own hot topics. We've been doing that since the end of August, and we're planning them through October. And so if you're interested in learning more about us, shameless plug, since this is our hour, please put your email into the chat. So if you're willing, we're happy to connect with you. And again, respond to the survey. Okay, shameless plug over. Please, let's continue questions.
Yeah. So Shreya Tawari, where are you in school?
So I'm from AUC School of Medicine. I'm 4th year. Right now I'm in Bronx doing my clinical rotations.
Okay, you said AUC?
Yes, that's correct.
All right. What hospital in the Bronx are you at?
Bronx Care Health System.
Okay, I'm from the Bronx. I think I said that. Yeah. So you might be. I can't see out the window to tell you, but those walls that looks really, really nice. It's not my block. You asked about just what are some of the most common health conditions in our pregnant population. Hypertension is very, very common. We have, I can have in my patient schedule 15-year-old who's pregnant and a 43-year-old who's pregnant. And so you're seeing hypertension with the extremes of age, and not all of it is chronic hypertension. I will say that in these 9 years, I want to say we've had at least 1 eclamptic patient per year, and they're almost always under 21. But we see lots of gestational diabetes and chronic diabetes, lots of hypertension, some growth restriction, and we do have some multiple gestation, but our practice is much more I would say more of a average to low income group, as opposed to patients who are frequently getting in vitro or something like that. Some of the other groups may see more multiples, but typically it's like twins. Our hospital has just started an REI service line. So there are private REI doctors in the area, but our hospital has a service line now of REI that will be launching later this year. So it'll be interesting to see how our patients gain access to those services. I do see patients for infertility as well.
Yeah, we've also had a lot of cholestasis and pregnancy. There seems to be an explosion of that. Lancaster is about 40% Latinx. And so I don't know if that's the reason. It just seems to have exploded.
Thank you.
Hi, my name is Javier Javier. I had a question.
Sure.
I guess I'm thinking about being a family medicine practitioner, but possibly being the only doctor and doing maternity care or OB care. I guess I was just wondering, what are some great things to do or think about throughout training to be able to deliver great care? Or alternatively, if it's easier, what are some pitfalls to avoid being in a position where you might feel like, I might feel like overwhelmed by having a case maybe like beyond me, but not having someone to like, maybe because I neglected something.
Can I answer as the non-family doc on this? So here's the thing, right? Here is the thing, Javier. You asked a very good question. And one of the things that I think about, or the way that I think about like choosing where you want to go to residency or choosing where you want to go to for medical school, and I have this conversation over and over again, you're literally choosing your parents. Like you're choosing what household do I want to grow up in. And if you had that choice to make, you're like, listen, I want to get all the skills that I need just in case if this and just in case if that. And right now, today, I could say, I want to practice rural medicine. I got to get the skills. But you know what? At the end, if you're like, oh, I actually changed my mind. I really want to be in a city, or I got married, or I met the person that I want to be with forever and they live in this place. I want to have all the skills that I need for whatever it is. I want to be able to pivot. And if my decision stays the same in 3 years as it is today, wonderful. But if it changes, I don't want to be stuck. So that's how I would look at it. And so I think that as you're looking at residency programs, it's like, where do you feel like these next 3 years would be nice, would not be a hardship, would give you the tools that you need to be successful in whatever the rest of your life is in family medicine, and where, you know, where you feel like you'd have a good upbringing per se. Does that make sense?
I think it makes.
I really like that too. I think the other thing that I oftentimes think about is exposure. Like, it's good to actually have exposure beyond what you're going to typically see. And I feel like our residents have exposure to a lot of pathology, unfortunately for the patients, but a lot of complications and a lot of pathology. And so they know how to recognize it. The most difficult thing, I think, as a practicing physician is to really not know what you don't know, right? Like, so if you don't know that somebody's coming in, and if they're, 4 weeks postpartum and they have a headache, and you don't really look at their blood pressure because you think, oh, it's a migraine headache. And then you don't realize, well, people can actually have preeclampsia 4 weeks postpartum. You can get into a lot of trouble, and that patient can get into even more trouble. And so I think it's really important to kind of have a sense of what places will expose you to lots of different types of patients, and to maybe have that exposure beyond what you might actually practice in your regular day when you're out of residency.
And I think to echo what Dr. Fife said, when I practiced in rural New Hampshire, I came out of Lancaster General. I knew all this stuff. I can do this. It was a small hospital where I managed ICU patients. I did inpatient. We had a nursing home. I did outpatient, and we also delivered. And I said, oh, I know how to manage X, Y, or Z. But you have to know what your local resources are, and what's the comfort of the team around you. Because yes, the physician is an important part of the team, but not the only one. You have to know what your resources are, what the capabilities are. And like both, Dr. Hamblin and Dr. Fife said, you have to know what the bad stuff look like. If you've seen an eclamptic seizure, that makes you look at every blood pressure for your patients. You need to see that spectrum. And so I think, and I totally echo what Dr. Hamblin says, go someplace where you're going to get strong across the board training. Get the training, and then you can decide what you want to do with it. You can pick and choose. Each of the places I've been, rural, urban, and now this mix, if you have that firm base, you can develop on it, and you can morph and adapt to whatever your community needs.
Thank you so much.
Hi, I have a quick question. Hi, my name is Prajesh. I'm from Xavier University, by the way. I was just wondering, just a general question regarding your family medicine program. Do you guys also do international outreach? Such as like international missions abroad?
Yeah, we have in the time of not COVID, we have we have strong relationships with a number of global health opportunities. I think I had mentioned earlier, you can take 1 month away in your second year, 1 month away in your third year. Our health system understands the importance of global health experiences, but they want our residents to be safe and get quality education and be in safe experiences. So with our health system, we very strongly vet experiences. So we have longstanding relationships with several sites in Guatemala, Tanzania. I mentioned Malawi. One of the graduates of our residency program, she graduated in the early 2000s, right from our residency, went and practiced in Malawi for 7 years, where she was medical director of a hospital. She came back to our residency program as faculty, and each year she goes back for a month and takes 2 or 3 residents to that hospital where she practices to mentor with them. So we, in addition, now that Lancaster General is part of Penn Medicine has a very strong global health network, and they also have a great series of classes and didactics to help people prepare for those experiences.
All right, great, thank you.
Pradesh, what school did you say you're from again?
Seba University.
Sabre?
Seba, it's in the Caribbean.
Okay, Seba. Sorry, I didn't hear you. Thank you.
No problem, thank you.
Hello, my name is Shika Patel. I'm a 4th year from Rowan in Stratford, New Jersey. And my question is pertaining to the type of support that exists for residents in the program, and if there's any kind of like formal mentoring available.
Dr. Fife, do you want to talk about that?
Yeah, I mean, I think we have quite a bit of formal mentoring going on. So, you know, we are a big residency with 39 residents, but we also have a very large faculty. And each one of us as faculty has advisees. We have between 2 and 3 advisees. And we have them with each class. So you, like as a faculty member, I don't have 2 people in one class. I have 1 person in one class, and then 1 person perhaps in another class, and rarely three advisees total. And we get to develop a strong relationship with those advisees. And usually I meet with them like when they're in orientation, and then after orientation, we get together on a regular basis. We also have a semi-annual review, which is just going over all of the rotations in which they participated in the 6 months prior, and going over how they fared in those rotations, and also offer career counseling in all of those. So that's one of the formal pieces of things, but there's a lot more informal that goes on. So when you're seeing patients in the office, we have typically 1 to 2 faculty that are assigned to precept. And usually it's 1 faculty to 2 residents, maybe to 3 residents, incredibly rarely to 4 residents. And so when you see your patients, especially as a first year in your first 6 months, you precept every one of those patients. And you actually get to know the faculty member. And we also have a very formal feedback. We have feedback Thursdays where we actually sit down on Thursday with each one of the residents and talk to them about what their goals were in that clinic, what kind of improvements they would like to make, what kind of things went well, what kind of things they were like, oh, this didn't go as well as I would have liked, and then offer them resources to kind of learn from there. And then each of the weeks in a rotation, so we have 4 weeks per rotation, we focus on one of the classes. So our first week, we focus on the first years, and we do feedback with them in clinic as well. And then there's feedback for each rotation. So this week, I'm our OB FP attending. And so I have 4 residents that are with me. 1 who's mainly focused on newborns, and 3 other ones that are focused on other areas in terms of maternity care. And I will actually provide them with feedback at the end of the week. Typically I do it in the middle of the week and at the end of the week. And so I'll sit down with them, and typically I sit down for about 15 minutes to a half hour with each of them, going over how things went in the week and what kind of instruction we can provide. And if somebody's actually struggling as well, we do try to even provide an individual education program for each one of the residents who needs it. So I think there's a lot of formal mentoring. The other piece that's important is that each of the classes, I think offers mentoring to the class that's below them in terms of a year. So the second years offer lots of mentoring to the first years, and the third years offer a lot of mentoring to the second and first year class. And they offer formal teaching, but they also have a great connection with them because our teams are made up of typically third years and first years and second years. And so they have a lot of interaction within that. I could be missing something. Pam, do you have other thoughts?
The other thought.
You're muted.
You just went to mute.
You're muted.
You have there's just
Okay,
5 minutes. There's just 5 minutes left.
Okay, I was swiping and I muted. The other thing I was going to talk about again was just our areas of concentration. As I mentioned, we have 17 areas of concentration, you know, those deep dives that you can do. A lot of those were started, the first 10 or so were started out of faculty interest, but then the additional 7 or 8, and it seems like each year we add another one, are based on resident interest. They're like, hey, I'm interested in this thing. And some of our faculty already are interested in it. So there's mentors, but if not, we put together people with other mentors in our health system, in our community. So the fact that we're so large really gives us a lot of opportunities for connections. So we are winding down. I guess we probably have time for one more.
Right.
Oh, okay. So I have a question. My name is Tim Marinier, and I'm a 4th year from St. George's University.
Mm-hmm.
I wanted to ask, how does your program fight resident physician burnout?
Live around.
Yeah, live arounds. We start in orientation, actually. Orientation is about 2.5 to 3 weeks long, and we do a lot of team building activities. And so right there, the class of 13 gets to know each other real well. So, you know, we attract residents from all over the country, and a lot of people have never been to Lancaster before. And so we put together a support system. And then, as mentioned, the advisors are very integral. We have wellness morning reports and sessions built throughout our didactic schedule. We have narrative medicine. So 4 times per year, you'll have an afternoon where you'll be with residents kind of focusing on activities around reflection of what we do in medicine. We have wellness, other wellness afternoons, which is basically, okay, this is your time. You have an afternoon or morning. That's your time to get your appointments done, go to the dentist, you know, get your car fixed. If you want to go get a massage, if you want to go for a hike, that's your opportunity for wellness. And then because our residency is so big, there's just so much camaraderie. All of the interns are off on Friday nights. So interns regularly get together for intern dinners. I don't know, Bill, help me out. What am I missing?
Yeah, I mean, I think the other thing is we try to listen to the residents. Like, I think one of the most important things to help with burnout is that you have a system that's going to change based on your needs and your interests. And so we have a meeting once a month for all of the residents to get together, and it's protected time where they discuss like what is not going well, what's going well, and it's just them. The first years also have actually a meeting once a month as well, where they just kind of discuss what's going on. Sometimes they're by themselves. Sometimes they could be with a faculty member if they desire to be with a faculty member, but it's just protected time to kind of discuss things. And then a lot of those things kind of percolate around the residency, and we make changes based on them. So I think that's an important piece of things to help burnout.
I also think, you know, LTH Home in the City program, where residents actually are facilitated to buy a home, and it's a very affordable place. So I think that this family medicine residency is a kind and gentle place. You get paid enough that you can actually live and have a decent life, and you can buy a place in the city. So I know that there's you still living. So I think that that's a part. It's just, how is it set up? Is it set up in a way that is going to make you hate life for 3 years and then try to massage it away with a, no, it's set up for success.
Dr.
Are we good?
Benenchek, I'm going to thank you and your colleagues very much for this session. We're going to bring things to closure now, and it's great that everyone joined in. Thank you very much.
Good. Thank you to the
Thank you.
FMEC for hosting.
Yeah, thank you very much.
My pleasure. Take care.